Hi, and welcome to Mind Your Health. Dr. David Burke. We have a lovely show for our audience today. I'd like to introduce Dr. Kurt Gambla. It's wonderful to see you.
Thanks for
I
having me.
have met you and had the privilege of interviewing you kind of throughout my career in the media, and it's been wonderful.
And we train our docs now, and our expectation is to do both of those things for
Okay.
everybody. Because there is some age-related, there is male-female related approach to things, but the universal approach is, yes, be skillful, but also be compassionate regardless. So it's a very high bar. It's hard for people to hit that all the time, and but we're pretty insistent on that.
Mind your health.
Got to mind your health.
Mind your health.
Treat yourself. You got to mind your health.
First off, let's talk a little bit about you. And then we're going to segue into a topic I think you and I have talked about a lot, and that, again, medicine at a crossroads, but a lot of different things going on. So let's first hear a little bit about you.
Yeah. Well, Kurt Gambla, I'm the Chief Medical Officer at Beaufort Memorial Hospital. I've been in Beaufort since 1990. Came right out of my residency. I trained in Chicago, and
I didn't know that. You're a Chicago boy?
I'm a Chicago boy. Yes, I'm trying to be a native, but they'll never let you be a native.
I'm
So-
Ohio girl. It won't happen.
Yeah. So sort of trying to fit in, but I came here originally with the National Health Service Corps, and did that for about 4 years with Beaufort Jasper Comp Health.
What did
That I was in private practice. I was in a big multi-specialty group, and then finally became employed by Beaufort Memorial in 1999 as an
Nice.
internist. Yeah, and so I did internal medicine from till about 2014, and then I transitioned into my role now, which is mostly administrative.
Which is really interesting, and I think will give you a really interesting perspective on what we're talking about. Do you want to kind of share the topic of today?
So, you were talking about emergent, urgent. I wanted to start with internal medicine.
Okay.
Yeah, so I was shopping for a new doctor, and the provider was family practice. I was like, do I need, what do I need?
Oh,
I'm
that's a
I'm
good
a once a
point.
year guy.
Yeah.
What's the difference between internal medicine and just a regular family practice
Family
doctor?
practice. Yeah, so internal medicine, think about family practice, but more adult focused. Family practice, they still do some peds, some of them even do prenatal care, some of them still do OB. Internal medicine is primary care, but just for adults.
Well, that's kind of interesting. As we're talking about treatment, and we were talking literally about an accident that happened, a really tragic accident. And I think when people get hurt in today's world, or they're sick, or I don't know, they've cut themselves, they have the flu, whatever, I get confused. When do I go to an emergency department? What is it now? When do I go to an urgent care, which I just think is a walk-in? And then to me, and this is where I get confused, there seem to be some hybrids out there now. And I think it's ubiquitous. I think this is all over the US, where I just am not sure how all of these things have emerged, when to go to what, and I'm going to turn it over to you.
Sure. So I think you defined the problem and the issue exactly. You're not alone in your confusion. Most people, when they have a sudden onset of a medical concern, they don't know where to go.
Right.
And the studies show that most people get it wrong. Now, thankfully, most of the time, people overestimate the severity. So probably about 40% of ER visits are things that could probably be safely taken care of in urgent care.
Okay.
Conversely, maybe 20% of people that go to urgent care really should have gone to an ER in the first place.
Okay.
But the point is, people get it wrong all the time. People aren't trained in triage. Triage is that sort of art science of, are you sick? And if you are sick, how sick are you?
Okay.
And lay people shouldn't be expected to
To
know
know
that.
that.
Right. But the problem is, if you go to emergency room for a lower acuity thing, you're going to get probably more care than you need and a much higher bill. If you go to express care for something where you should have gone to emergency room, there's a time delay there, and that could make you sicker. So there's issues with either one of those. And so that's, I think, what the genesis of the hybrid was. Now you have one doorway, all the care you need, and you don't have to figure it out. The health professional, once you walk through that doorway, they do their assessment. They're going to figure out go to the left or the right, depending.
So what's the difference? Emergency department seems to me, I don't know how to say this in a cool way, but like full service.
Right.
The hospital's there, everything is there, boom. Then urgent care, I think of as bump
alone.
scrapes. Yeah,
Yeah.
exactly. Let me just
You're
make,
not that sick, have a seat.
that's right, exactly. And then, so it's this new model that I'm more confused about what they do.
Yeah. So the hybrid model, really think about an emergency room, full
Okay,
service emergency room that where they built a express care or an urgent care right next door, and they knocked down the wall between the two.
perfect.
So you have everything you need for a full blown emergency, but also the option to sort of go to the other lane and just get the
Quickly.
emergency room light.
So,
Are there ever, I don't know how to say it, like non-negotiables? If you're having chest pain,
Right.
all bets are off. Go to the emergency room.
Yeah. So the best
If
way to think
you're
about where to go. So the beauty about the hybrid is it's all there. You don't have to decide. But if you're,
oh,
but say you don't live right now, there's not a lot of these. We're going to be the first one in South Carolina. There's maybe 24 or so
okay,
in the nation and maybe 10 states. So right now, not everybody's going to have that option. Not everybody's going to live within striking distance of a
sure.
hybrid. So if you're trying to decide, the best way to think about it is it getting worse? And am I likely going to die or have a permanent damage?
Mm.
If the answer to that, either of those questions is yes, go to the emergency room. Or if you're in doubt, always default to the emergency room. It's better to have a higher bill and more care than to go to somewhere where they're going to just end up sending you to the emergency room and can have that delay. So if I'm just uncomfortable or a minor injury, that's when you think
Right.
express care or urgent
And
care.
because I'm a psychologist in today's world, I do lots with mental health things. And I know that that's always a question for mental health professionals is where do I send a patient that may be having a mental health emergency? I can't separate brain and bodies, but I don't really know what the appropriate protocol is for that.
Yeah, mental health emergencies, the default is always to the emergency room because there's such a wide spectrum of things. And, if you get that wrong, you
Oh,
can have
exactly.
serious outcomes. And emergency rooms are two things. One, the initial assessment and stabilization.
Okay.
They're better at that than an express care or an urgent care for mental health issues. And then they can plug you into the hospital. Most of them are still attached to hospitals. So they can plug you into the hospital if you need to or get you transferred, et cetera.
What do you think makes a good patient for any one of those places? What should I come armed with? In other words, as a patient, do I come by myself? Do I bring someone with me? What helps you? What helps you help me?
Mhm. So it's always a good idea to bring somebody with you because when you're sick, depending on how sick you are, you're not always in your best state of mind, having your best day.
Okay.
So it's always good to have an advocate, a second set of ears, and a second mouth. Maybe you're leaving something out in your history that they can remind you about. And so absolutely always bring an advocate with you
Okay.
when you can. And then in any history that you can bring with you, list of medications or the medications
Yeah.
themselves, those are key. The things that people need, sort of the bare essentials when you're in an emergency setting is kind of what's your complaint, of course. But then
Right.
briefly, what medical history do you have? What medications are you on? What maybe were the most recent events that led up to this? That's kind of the bare essentials that somebody's looking for when they're trying to do a quick assessment and triage you in the emergency room. Or
What about insurance? And I mean, is everybody, this is a what's a terrible question. Is everybody treatable, whether I have insurance, whether I don't have insurance, whether I'm
yes, so they're never going to turn you away. Insurance is nice to have,
yeah,
and to bring with you. If you forget it, they're not going to tell you turn around, go home, get your insurance
right.
card, and come back. We're always going to treat for in most emergency rooms and urgent cares. They're going to treat first and ask those questions later. The key is to take care of you, make sure you don't have a life-threatening illness or injury, and we'll figure out the payment somewhere down the road.
It's so funny because go ahead.
I was gonna say, I wanna switch gears a little bit, and I hate to bring it up, but your friends in the legal profession, I go into the doorway where I can go on either side, and I've got stomach pain, and provider says, "Oh, you're good. Go here to urgent care." Well, it turns out it was, something,
Not good.
yeah, something really bad.
Right.
Is that doctor liable? Is it? How do I? You're putting an awful lot of weight of, a diagnosis in a hurry to tell me where to go.
Sure.
See, these are the
So
fun questions,
yeah.
right?
So anyone can get sued for anything.
Oh,
Depends on how I'll
Witnessed.
say
I can attest to that.
how
Yeah.
ambitious your attorney is.
Yeah.
But I think that in medicine is always going to be an inexact art science, right? So we do the best we can. I think the advantage, though, again, of having a hybrid where everything's together, let's say the initial evaluation is off. I think that you have stomach flu and it really ends up being appendicitis. Well, that's going to hopefully get vetted out during that visit there. And so you're still in the
Oh,
same
so I
setting.
can go in. I can be there a couple of hours before even that decision is made.
Sure. Yeah.
So after the X-rays are back, the labs are back, and you know what? You're good. You're not having appendicitis. Everything's
Mhm.
good. We're gonna move you here.
Right. You're not locked in
Okay.
from which
Okay.
direction you go when you.
There's not a guy standing at the door saying, "Okay,
Right.
door A or door B."
Yeah, no,
Right.
that's it. No, it's
Alright.
it's much more fluid situation than that. But the nice thing is, so if you go to emergency room now, freestanding emergency room or an emergency room attached to a hospital, you're going to get an ER bill, regardless of if you have a minor cold, whatever it is. If you go to the hybrid, your bill is going to be determined sort of on your final disposition.
Mm.
So
Okay.
if we think you have appendicitis and it ends up just being stomach flu, you're going to get the urgent care bill for that, not the.
Not that you had a surgery bill.
Right, correct.
So is it? Would you say is this the wave of the future, moving emergency departments more to where people are instead of attached to a medical center? I mean, we live in a pretty rural state.
Yeah.
So is it better off to stick small freestandings in
Yeah.
all over the place?
What is the
I think-
mindset for
Yeah,
that?
I think this is the innovative strategy because there's sort of the triple aim is want to get the right care at the right time, access,
right
which
time.
is have a bunch of them
Yeah.
spread out, and then be good stewards of resources, meaning don't use more resources and don't overbill
Mm.
for something which, again, you don't have a choice in an emergency room, but in this new hybrid setting, we have a choice of how to bill.
Mm.
Which is really interesting. I watch way too much Grey's Anatomy in the pit. But with that said, so do a lot of other people.
Sure.
So I think expectations of what an emergency room does, can do, should do versus urgent care versus this new hybrid model is something that we're all really curious about. And, again, there's so many words, trauma one or level one, level two. If I call an ambulance, why, and I want to go to Beaufort Memorial, why do I have to go to Savannah or whatever it is? How does all that play out or work?
So there's a lot that goes into the triage if you call an ambulance. Of course,
Okay.
if you're what we call POV or coming with your own vehicle,
Okay.
you get to choose where to go.
Okay. Yeah, you drive it.
Right, right.
right,
It's a
okay.
little more complicated, a little more nuanced. Now, depending on the level of emergency, EMS has some discretion.
Okay.
They may say, depending on traffic and how
Right.
sick they think you are, and did you verbalize the presence. The default is they're going to take you to the closest emergency room.
Got it.
But if you're maybe not that sick and they think it's okay, they may be able to honor a request to go by an emergency room and go somewhere else. If you're having a heart attack,
You're
or
going wherever.
you're in a major
Yeah.
motor vehicle accident, you have trauma, you don't get a choice, and they don't have a choice either. They have to take you to the quickest place to get you plugged in there to get the
Mhm.
emergency treatment.
And are there different levels of emergency departments?
There's level one, level two trauma,
see.
and that really just depends on how many specialists they have, how good the technology is. Most of the ones here are sort of a level two or level two equivalent, which means we can take care of most major things and stabilize you. Now, if you have a neurosurgical emergency or some type of thing that are a little bit more complex, then the goal would be to still do a great job of stabilizing you and then plug you into a tertiary care center, whether that's MUSC or Memorial.
And I was going to say, do most hospital systems play together pretty well when it comes to that? I mean, it's been my experience that they really do, even in a climate where sometimes it's not always rainbows and butterflies. when I have a mental health patient, they almost always go to you.
Yes.
And so I guess that makes me proud and hopeful of our systems. And is that pretty much how that works?
I think there's a general philosophy and consensus that we'll figure it out, even if we might be competitors in
Yeah.
pocket. Um, the healthcare professionals, I think, all sort of follow the same credo. Let's get the patient to the right level of the patient comes first. All the business aspects, all that other stuff is really a secondary concern. Um,
And that's what I think we should talk about too, because I think that's so important, quality of care.
yes, yeah, absolutely. We don't. I can tell you that most emergency docs, they don't they don't do the wallet biopsy. They don't worry about who gets more patients, us or the
Okay.
hospital down the street. That patient's here, they're sick or injured. We're going to take care of them, and all that other stuff comes later,
Comes later.
if at all.
I wanted to touch base on the almost the opposite of acuity is unfortunately because the shortage of providers. I personally know a ton of people that use the emergency room as a doctor's office. There's urgent care, but they're closed at 6 o'clock. They're not open
Yeah.
on Saturdays. They're not open on Sundays, and they've been sick all week. So it's now Sunday afternoon, and they're green gobbledygook, and they go to the emergency room. And I get it. The United States is the finest healthcare in the world, probably the most expensive healthcare. How can we keep those people out of that most expensive? Because not take care of people, but this is not a place for you. And then they've also waited all week. They've been just doing damage to themselves because they can't get into a doctor, and now they're going to the ER.
That's right. Yeah, they come sometimes at the 11th hour.
Right.
But that's true. A lot of the emergency room visits that we see early morning, evening, or on the weekend, they're literally there because they might have guessed right that I only need urgent care, but the urgent care, they're not open 24 hours. A lot of them are not. So that's the nice thing again about the hybrid model. It's a 24-hour model. You're open all the time.
Well, and this is super. We love to have you captive so we can ask you all these questions. So again, typical. I was in the emergency department and I waited for an hour and a half, and whatever. How are those decisions? I think there are a lot of people who aren't really sure how the decisions are made. Who come? It's not first come first serve necessarily.
No, it's not. It can't be. So it's based on, again, triage. And triage is the whole art of how sick are you?
And I love that you said art.
It is an art. It's an art
Yeah.
science. There's some science to
Yeah.
it, but it's really, there's some art to it too.
Sure.
And so that is the skill set that we rely on when you first walk in the door. Our providers, between asking you a few
Sure.
very focused questions, doing a quick exam, trying to understand two questions: one, sick, not sick, because you do get a lot of worry, or
Right.
some worried well, and they just need that reassurance.
That's right.
So that's great. We're
Okay.
going to
Sick,
tell you
not sick.
sick, not sick, and then if the answer is sick, the next question is how sick.
Okay.
And they call them SI levels, so there's sort of 5 levels of how sick,
Okay.
going from the most serious, you're about to die, to you have the flu, you'll be
Right.
okay, we'll give you some.
You feel yucky, but we
Right.
got you here.
Right, and go home. So that's kind of triage. And so if you are a level 4 or 5, meaning very low on the scale, and you come in and you check in, and a level 1 or 2 comes in after you, they're getting priority seating because we have to take care of the sickest patients first. And it's very inconvenient if you are that level. You
Right.
feel sick, you're not comfortable, you don't want to sit out in the waiting
That's
room for
right.
hours at a time. But medical necessity sort of dictates we have to take care of the sickest patients. So it's absolutely not first come, first serve.
It's
I need to apologize. When you said, how sick, are you sick? How sick? I used to get in so much trouble. We'd travel with the kids, and one of them go, I have to go to the bathroom. And I would say, well, how bad do you have to go to the bathroom?
exactly.
And
Yeah.
my wife would you have to pull over. I'm like, well, we have to pull over right now. But
Yes.
I totally,
And that's the empathy we have to have for patients, right? Because your perception of how sick you
That's
are
right.
is going to be different than the objective, what
That's
is the
right.
lab showing, all that.
I have my finger here and it looks really bad.
Yes.
It's supposed to be here.
You might feel like you're dying. So
Yeah.
to you, you are dying, right?
Right.
But so we have to use some more objective measurements and things to triage.
Are patients tougher than they used to be in what they demand or expect? Because I think the last couple of times I was at the emergency room, what I saw that was really different was the level of communication was much better. I felt like the folks who were in the waiting room, not a lot, but there were times when people came out. I was at Buford and they came out and they said, you know, we're still here, hang in there, you're not alone. And I, for some reason, it was so reassuring.
Mm.
They were being treated, but they were being treated not like objects, but more like people. Is that something that
That's been
hospitals in general are trying to?
yes. So patients are getting more demanding in terms. I wouldn't say more demanding. I think they're being more um,
Discerning about,
consumer
yeah,
savvy, yeah,
Mhm.
okay.
and discriminating. And so the credo for centuries, going back all the way to the Hippocratic Oath, this is actually a misquote. Everyone thinks it says "do no harm." It doesn't say that exactly, but the idea is, for centuries, what we thought was doing a good job as a medicine was, "Don't harm me, heal me," was what the patients expect and what we
Mm.
need to
Okay.
deliver. And we were happy with that, and patients were frankly happy with that
Sure.
for millennia. And then the new concept, "be nice to me," came out. So we still have to not harm you and we still have to heal you, but also we need to do it in a more welcoming environment, a more spa-like environment
Mhm.
where it's possible to do that. And certainly a more consumer-friendly environment, because if we don't harm you and heal you, and we're really good at that,
Yep.
and the
But
hospital
we're
down the
jerks,
street's really
but
good at
yeah,
that,
right.
but they're nicer,
Yeah.
the physical plant is cleaner, more modern. Um, People, when they have a choice, are going to go to that
Mhm.
hospital. They're going to use their
Well, it's
consumer.
interesting that you say that because I mean, you can read reviews and
Next door.
scores and blah, 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 blah. And in psychology, it's always clear as kind. If I know and I understand where I fall or what, just communicate, I can deal with anything. But I think to your point, as long as the clarity is said in a humane way.
Yes, I think that's exactly right. It's the message is part of it, but how you deliver the message. And a lot of times that's the part people are going to remember. They expect to get taken care. They expect the medical part, the technology part,
Mhm.
to be all there. And so that's just sort of a given, and they assume so. Where they're going to discriminate and discern is on all of those other sort of creature comforts that for years we
We didn't
thought
even,
were incidentals. We thought,
correct.
and they're becoming increasingly important.
And again, because we wouldn't be mind your health if we didn't ask tough questions, I think one of the tougher questions that a lot of people have now, at least my friends who are physicians, who are seasoned physicians, say they grew up in an environment, well, they went to the emergency department, they went to the doctor, they went to the hospital. The physician and the team told them what was wrong and what the treatment options were, and that's what happened. Now I sense a climate where there's a lot more fear around, do I really want this? Do I need this?
Mhm.
I don't believe in this.
Mm.
I don't, you know, how does all that play in today's climate in the world of hospitals and urgent cares and
Yeah,
emergency departments?
it's trickier because everybody in their mind is still saying, "Who's the doctor here?"
Right.
Right?
Right.
And I
No,
think
they
it's
are.
yeah, but they're not
Mhm.
going to say that out loud
Right.
because it has to be more collaborative. And frankly, patients are much more savvy about their health.
Mm.
I mean, you have AI, you have you
Right.
have all of these
This
resources.
celebrity said I can't.
Right. And so it's tricky because there is a lot more information out there.
Mhm.
There still is a lot of misinformation out there. And so I think the goal of the provider is to, if you're a little bit off on your diagnosis, and mine might disagree a little bit, to sort of find the middle ground with you, debunk
Ah,
whatever myth there is there, but to do it in a kind and supportive way and not in a condescending way or
right.
an off-putting way. And for us old school guys, that has been an evolution over time. I think that they're training more and more on that. So the newer
Okay.
generation is getting that and coming up with that training. That wasn't the thing. A good doctor back in my day was, you're technically good and we don't care that much if you're a jerk or a nice person or not.
Mhm.
You're technically good. That's all that matters. That won't cut
But I
it
would
anymore.
imagine in an emergency department when time is critical, it has to be frustrating sometimes to have to sort of do that middle path stuff if time is of the essence when
Well, I thought you were going to go and I get it, how the consumer is more savvy and more in tune to what they want, but there's no empathy for the physician coming over.
Right.
His patient just died, or a little child is
Right.
deathly ill, or you don't have no, or he's been up for
Right.
18 hours. They have no concept of, once again, and I get it when you're in the emergency
Well, I
room,
want you
but
to
it's all about me.
right. I want you to treat
I've got
me.
10 people I'm
Right.
trying to work here.
That's a good. That's
and
a great point.
It
that you
really
make,
is.
is to you that interaction is the whole universe,
correct.
right? And you want me to think of you as my whole universe. But I've seen maybe 20 patients before you. I might have 20 more out in the waiting room. All that's running in the background, but I have to focus on you, and you deserve that, and you expect that. But that is a challenge that I think is overlooked a lot of times. by
I think
patients.
it truly is.
Hey,
Well,
So
absolutely.
people seem to be so quick to blame, the doctor wasn't nice, the doctor didn't do that, the doctor didn't do this, that. I guess what I'm saying is it would be nice to sort of shift the commentary to what am I doing right instead of what are they doing wrong is really what you're saying.
oh.
And recognizing that doctors are more than just objects and technicians.
Well, it's a difficult position. So I get, look, if I'm having a chest pain, I don't care if you're a nice guy. You don't have to speak nice words to me.
Right, to save your
Just,
life.
just exactly right.
Right.
Fix me. Stop this
Mhm.
heart attack.
Yeah.
I'm good. We can be friends. We'll golf later. I
Right.
get it.
That's
But what's
No.
funny is for me,
Right. You go in and
I go in
Right.
and I want you to say, you're going to be okay.
Yeah.
yes.
Let's take a moment. We're going to do everything we can. And I'm going to feel like I can
that
relax.
you've been cared for.
Correct. It's so funny.
Good.
Yeah, it is. Well, and we train our docs now, and our expectation is to do both of those things for
Okay.
everybody,
Mm.
because there is some age-related, there is male-female related approach to things, but the universal approach is yes, be skillful, but also be compassionate, regardless. So it's a very high bar. It's hard for people to hit that all the time, and but we're pretty insistent on that. And if people fall short, we have those conversations.
But just being able to have this open conversation in a format or setting like this, you don't seem pretty shaken by anything we've asked. And so that tells us, I think, that this is not some new concept to you. These are things you deal with every single day.
Yeah, it's our reality today. It's been an evolution over time, but that is our reality today. I might be thinking some things in my head.
Oh, I was going to say, I don't want to, yeah, I'm thinking it, but I'm not going to say, we call that filtering over here.
It was funny too when you say, it's a high bar to meet. So now here you've been educated for how many years and in practice for how many years that compassion is still a high bar to reach where you've dedicated your whole life to compassion.
Yeah.
It just seems such
Yeah.
a
Dichotomy or,
Correct,
yeah,
right,
it does seem
right.
like a,
Well, and the thing to keep in mind though is you can't actually train people to be compassionate.
Mm.
So the way that you hopefully develop providers that are starts all the way with medical school selection. And that
oh,
process.
interesting.
And people either have that capacity
Mhm.
and you can sort of coach them on that. Or if they don't, they're going to tap out, or someone's going to tap them out before
Okay.
too long. You can't do this for 20, 30,
Yeah,
40
I was just going
years
to
and
say,
not care
doesn't
about
the
people.
system weed that out? I mean, I don't know how you can go to 4 years of college, 4 years of medical school, 2 or 3 years, specialty, and
Interns.
then all that, and not be a compassion and dedicate your life to whatever specialty, but helping someone else. How
Well,
you can come out not being
Well,
compassionate.
because it would depend on if your technical acumen, if that's kind of the way your brain works with some
I get
neurodiversity or just seeing it through a different lens. I mean, I don't really care about you. I care that your hurt gets fixed.
Yeah, I get
You know what
that.
I'm saying?
Yeah.
And I mean, I want to be nice to you. I'm doing it because I care about you, but
Well, and I'll just fix your heart. That is necessary, but not sufficient anymore. We
correct.
just don't. The whole system, from again medical school on, we try to emphasize that, and so there is a lot more emphasis on understanding a lot of psychology. A
Yeah.
lot of what we do, regardless of the specialty, is psychology.
Hmm.
So there's more emphasis on that.
Oh,
Right.
that's what we need. More shrinks.
No, we didn't say that.
I did.
I know, but psychology, we're just thinking about logic
See
and
what I have to
emotion
deal with.
together.
See what I have to
You're
do.
being analyzed
Every
right
time.
now.
Oh,
It's all
oh,
good.
Well, she doesn't hesitate. Yeah, she doesn't charge
My
you.
wife's in your profession, so I'm used to being
Exactly.
around
I
this
do
stuff.
know
Yeah,
that.
right,
It is wonderful. But I think this whole topic and opening up this conversation has really been enlightening. And I think, you know, we're really, really pleased to have you here. And thank you for kind of being open with us and sharing from your lens, the way you see this kind of new hybrid
Yeah.
coming into play. It makes a lot of
Makes
sense.
everybody wins.
They really
It's less
do.
expensive. It's the care that you need. It's to be able to go here or there. Yeah. I get well. Is it the same physician on both sides? If I'm
Yes.
here,
Oh,
I'm in there. I'm in
interesting.
here
Yeah.
for 2 or 3 years, and I've been seeing Dr. Jones, and he's cut me. Hey, your labs are good. We're going to do the chest X-ray. Then everything comes back. You know what? You're good. I think it's flu. I think it's something else. And I go to the other side. Do I still see Dr. Jones?
It's
Okay.
gonna be one doc. Now that doc will be supported by a
Staff.
emergency trained
I'm
nurse
mid-level. I
Yeah.
get that.
levels
But,
as well.
right.
But there's
Yeah.
continuity of care.
Right. But
Yeah.
your urgent care doc and your emergency doc are gonna be
Okay.
we might give them different hats to
There you
something
go.
like that. So
How
you can
cool
do
is
business.
that?
Yeah.
And then you go downhill from there. Pretty soon you're like the janitor checks you out. Or
Exactly. Well,
Cookies out of the room.
exactly. Dr. Kurt Gambla, thank you so much for joining us today on this podcast. And we thank all of you for joining us here on.
Mind your health.
It's been a pleasure. Thank you.
Uh-huh.
Mind your health. Mind your health.